Ladies and gentlemen, welcome to MedSynapse podcast series. I'm your host, Dr. Nigar, and today we have the privilege of hosting Dr. Rutendo Rukarwa, a dedicated consultant specialist physician and rheumatologist at RheumaMed, Botswana. With a passion for patient-centered holistic care and a commitment to evidence-based medicine, Dr. Rukarwa brings extensive expertise in managing general internal medical conditions, joint and muscle issues, autoimmune diseases, and connective tissue disorders. Our focus for today's discussion is the challenging world of treating rheumatoid arthritis. Tune in as we delve into the complexities of this condition with Dr. Rukarwa's invaluable insights. Welcome, Dr. Rutendo.
Hi, Dr. Miguel. Thank you so much for having me, and thank you for the opportunity to discuss this topic that's very relevant for most people, which I hope people will benefit from.
Thank you so much for joining us once again. And without further delay, let's begin with our podcast. Dr. Rutendo, to begin with, what makes rheumatoid arthritis difficult to treat, and how prevalent is it?
So with rheumatoid arthritis, there's a concept of what we call treat to target, which is a strategy that advises an agreed disease activity target for our patient. So when a patient starts treatment, you want them either to get into remission or at least low disease activity using the various disease activity indices that are available. And this informs whether you're going to escalate or change therapy in your patient. However, for a number of patients, they remain symptomatic despite the recommended treatment changes, and this leads increasingly to what we now call difficult to treat rheumatoid arthritis, which is a heterogeneous group of people or patients with multifactorial disease states. So prior to this definition of difficult to treat rheumatoid arthritis, there wasn't any uniform terminology, or it wasn't really clear which patients fit into this group. And different terms have been used or were used, such as complex rheumatoid arthritis, severe rheumatoid arthritis. Some people termed it multi-drug or treatment-resistant rheumatoid arthritis, and refractory rheumatoid arthritis were some of the terms used. But now, universally, it's becoming known as difficult to treat rheumatoid arthritis. So Euler Group Task Force in 2021 finally came up with what is now a definition for this difficult to treat rheumatoid arthritis patient, which includes both intra-articular and extra-articular components, and all three of the following need to be present for a patient to be defined as a difficult to treat rheumatoid arthritis. So the first has to be a treatment failure history. Second is characterization or presence of active or symptomatic disease. And thirdly, the clinical perception of both the treatment doctor, who's the rheumatologist, and the patient that the disease indeed is difficult to treat. So when it comes to the prevalence of this difficult to treat rheumatoid arthritis, it falls between 5 to 20% of all patients who've been diagnosed with rheumatoid arthritis, which can be quite high. And the differences in the prevalence is because every study, there's study-to-study variations in the definition, which is why there was a need for standardization to try and come up with one term or criteria to define this population, to try and make them more homogeneous and get away with the differences in definition or classification criteria.
Thank you so much for the brief overview, Dr. Rutendo. Now, moving on to our next question, what are the specific components of each of these classification criteria for rheumatoid arthritis?
Okay, so when we're talking about difficult to treat rheumatoid arthritis, firstly, we spoke about the need for a history of treatment failure. And how Euler has defined this, it is that a patient needs to have used at least 2 or more biologic or targeted synthetic DMARDs with different mechanism of action. And this is after having failed your conventional synthetic DMARDs. So this is a patient who probably started off with methotrexate, leflunomide, or possibly chloroquine and sulfasalazine. Those are your conventional synthetics that we normally use. Was then escalated to a biologic, either a TNF, an anti-leukin 3, or a JAK inhibitor, which are your targeted synthetic DMARDs. So this patient needs to have used at least 2 or more different biologics with different modes of action, and a targeted synthetic DMARD after having failed your conventional synthetic, unless contraindicated. So rarely we have patients who, for some reason, cannot tolerate or cannot use your conventional synthetic DMARD, go on straight to use your biologic. And this also incorporated, unless there's restrictions in socioeconomic factors. So for example, in third world countries where you can't really have or don't have accessibility to biologics and targeted synthetic DMARDs, this definition becomes a bit tricky because not all patients will have cycled through at least 2 biologics or targeted synthetic DMARDs, and then the definition has to be tailored to what is available in the country. The second component of the criteria, which is signs and suggestive of symptomatic or active disease. So the patient has to have at least one of the following. Either when you do your disease activity indices, your DAS28, CDI, you need to have at least moderate disease activity using our composite score. There has to be either the presence of signs or symptoms of disease activity, such as your elevated inflammatory markers, PSR, CRP, or evidence on imaging, such as ultrasound scans showing evidence of synovitis, or other extra-articular manifestations of disease activity, such as vasculitis or scleritis, or the presence of interstitial lung disease, for example. The other components suggestive of disease activity or symptomatic disease would be the inability to taper steroids to below 7.5 milligrams of prednisone. So our current EULA guidelines advise that when you're initiating therapy, conventional synthetics, or when you're escalating therapy, patients should ideally be bridged with the lowest possible dose of prednisolone or equivalent. And then the aim is to wean the patient off and hopefully to stop the prednisone. But if you find that a patient, you have changed therapy, however, when you start weaning off the steroids, the patient becomes very symptomatic and you're not able to go to a dose lower than 7.5, this by definition shows that the disease is still active and and possibly likely difficult to treat. Other evidence of activity would include rapid radiological progression of the disease, with or without signs of disease activity. So these are patients who maybe, for example, on radiology using X-ray, using the modified Rodman, not modified Rodman, your modified scores for presence of erosion, showing 5 or more within a year. So evidence of radiological progression with erosions, with or without disease activity. And then lastly, when you have well-controlled disease, however, there is reduced quality of life. So a patient might actually not have any active synovitis, clinically. However, their quality of life is reduced. They complain of a lot of fatigue, maybe a lot of tiredness, constitutional symptoms. That can actually be also brought in as active disease. And the last component that needs to be present is when there is management of the signs and symptoms is perceived to be problematic by the rheumatologist or doctor treating the patient and or the patient. So the patients themselves are feeling that their disease is not well controlled, it's problematic, or the doctor has cycled through a lot of drugs, has tried this and that, and still they're finding that the patient either is not resolving or remains symptomatic, and that by definition. So the presence of all 3 criteria needs to be present for them to have a patient defined as a difficult to treat RA patient.
Dr. Rutendo, our audience would like to know, why is treating rheumatoid arthritis complicated?
Okay, so these patients with difficult to treat rheumatoid arthritis, firstly, they are very heterogeneous. Remember, with the disease of RA, not every 2 patients present the same. They are quite different in terms of how they present, quite different in terms of progression of disease, extra-articular manifestations, disease severity, and all these things make it difficult to tailor treatment specifically to a heterogeneous group to treat everyone. And because of this, it becomes multifactorial when it comes to why it's complicated to treat these patients. There is persistence of inflammatory activity, which can be as a result of resistance to your DMARD. So you do give the patient, you escalate therapy according to your guidelines, but the patient doesn't respond, and this could be due to the resistance of the disease to the specific treatment itself, which makes it complicated to treat. Another issue is limited drug options due to either adverse drug reactions. So, for example, your patient needed to be escalated maybe to a TNF inhibitor, then they develop a malignancy, or they develop TB, for example, and now you can no longer use those biologic treatments because of the adverse drug reaction and or comorbidities associated with the patient. So, for example, patients with heart failure, New York Heart Association 3-4, it's contraindicated to use some of the biologic agents such as the TNF inhibitors like rituximab in this patient. So this then prevents you from actually escalating therapy and actually getting into a disease state of remission or low disease activity. Another important thing that is there we need to bear in mind is resource limited area. For example, us in sub-Saharan Africa and Botswana and other low-income countries, you find that there's limited access to these expensive drugs. So as much as you'd want to do things according to the guidelines, change therapy, change mode of action, use biologics, use targeted synthetics, not a lot of people or patients can afford this, and the resources are limited due to access as well as the expense associated with the disease. Another thing you need to look out for is whether there's any issues of treatment non-adherence, and this could be multifactorial. So, for example, patients usually with rheumatoid arthritis, most of them there's polypharmacy involved, so they take a lot of drugs, not just for the rheumatoid arthritis, but also for other core and multi-morbidities associated with the disease. So you find issues of adherence to medication, could be because of pill burden, could be because of adverse drug reaction, could be because of concerns of adverse drug reactions. For example, once you educate your patient that, for example, using a JAK inhibitor can increase the risk of venous thromboembolic phenomena, the patient might actually be hesitant. So they go take the prescription, may not take the medication. So these are things that bring about this difficult to treat rheumatoid arthritis. And lastly, we have concomitant disease or syndromes that are associated with rheumatoid arthritis, which make it difficult to treat. For example, fibromyalgia, which is usually secondary in this patient, or they can have secondary osteoarthritis, they can have mood disorders such as anxiety and depression, which is all associated with poor coping mechanisms, and this can result in non-inflammatory symptoms. So remember when we spoke about the criteria, what does the patient perceive as their disease not difficult to treat? So these might not be subjective inflammatory symptoms, but non-inflammatory symptoms such as your fatigue, your pain, which can then mimic the inflammatory ones, and this contributes to your difficult to treat rheumatoid arthritis. So all these things make it quite difficult to actually treat these patients who have by definition difficult to treat rheumatoid arthritis.
Now, moving on to our next question, are there any risk factors associated with development of difficult to treat rheumatoid arthritis?
So difficult to treat rheumatoid arthritis can be due to either persistence of inflammatory and non-inflammatory symptoms, which are less objective than the inflammatory ones. We can actually divide the risk factors into two broad main categories. One would be the factors that are associated with which cause drug ineffectiveness as well as adverse drug reactions. So you're giving your patient the adequate or you've escalated your patient according to the guidelines from which drug to which drug, but because of certain factors that can result in ineffectiveness of the drug or adverse drug reactions, you end up having a patient defined as a difficult to treat rheumatoid arthritis. So some of these factors resulting in drug ineffectiveness include obesity. So patients who are obese can actually have less drug effectiveness as well as more severe drug adverse reactions. Smoking has been known to cause ineffectiveness in some TNF inhibitors as well as some conventional synthetic DMARDs. So you always want to address smoking and smoking cessation, which is important in this patient. There could be other genetic factors that can result in ineffectiveness or higher risk factor of developing difficult to treat rheumatoid arthritis, such as, for example, females are more prone to developing it compared to men. You find certain races, for example, the Japanese, have been known not to tolerate high doses of methotrexate, which we know is our backbone drug in rheumatoid arthritis, and you'd want most patients to be on it, whether to manage the disease itself or to use it to reduce your anti-drug antibodies developing with use of biologics. And this you'll find once you're not able to use it in certain groups of patients, this can also lead to the development of difficult to treat rheumatoid arthritis. Other factors that play a role in the development is immunological background of the patient. So each patients are different, which is why it's very heterogeneous. So the immunological backbone of your patient would actually determine whether they are likely to respond to certain treatment versus other. We also have factors such as your drug pharmacogenesis and the immunogenicity of the biologic DMARD. So you find patients can develop anti-drug antibodies, and the effectiveness of the biologic DMARD becomes less. And all these factors then result in patients developing resistant or difficult to treat rheumatoid arthritis. Another thing, broad category, is the comorbidities as well as the negative outcomes associated with rheumatoid arthritis. So you find that as a result of the damage from the disease or from comorbidities and multimorbidities associated with rheumatoid arthritis, you actually find these patients become difficult to treat, not per se because of active disease, but because of symptoms resulting from this. So, for example, patients with secondary fibromyalgia, they can have persistent pain, persistent fatigue, not because of the rheumatoid arthritis, but because of the fibromyalgia. Patients who develop osteoarthritis or with concomitant osteoarthritis, which we all know doesn't respond to our DMARD, but there's different other ways of managing the disease. Patients who have interstitial lung disease as well as other extra-articular manifestations have also been found to be at higher risk of actually developing difficult to treat, especially at baseline. Cardiovascular disease, which we know is higher in these patients with rheumatoid arthritis. Presence of infections such as persistent periodontitis, which we know is involved in the pathogenesis of the disease, need to be addressed, as well as mood and psychological psychiatric diseases that can be present in your patients, such as depression and anxiety. And if these are not dealt with, then the higher chance of the patient actually developing the difficult to treat rheumatoid arthritis. Besides this, you also there's been a relationship with patients having high disease activity at baseline. So at diagnosis, if the patient has very high disease activity, elevated autoantibodies like the rheumatoid factors and anti-CCP, as well as other poor prognostic factors such as presence of erosions, these have been associated with a higher risk of developing difficult to treat, and of course non-adherence and inappropriate medication use. So there's a part that doctors need to play as well to make sure patients are on appropriate treatment, and also optimize and monitor and look out for adherence issues that can contribute to this phenomenon.
Thank you so much for highlighting the main risk factors that are associated with the development of difficult to treat rheumatoid arthritis. Now, moving on to our next question, is there a way for doctors to identify patients with difficult to treat rheumatoid arthritis? And if yes, how can it be prevented?
So certainly, the main thing we need to, the take-home message basically is that this is a very heterogeneous population with the various contributing factors. So you need to look at it at a patient-to-patient basis. So one thing that can actually help is early identification of those at risk of developing difficult to treat, and then optimizing or maximizing their therapy earlier on compared to those without the risk factors. So looking at some of the risk factors we mentioned above, for example, females, patients with high disease activity at baseline, the number of prior treatments used. So say your patient has already been on methotrexate, you've added on your leflunomide, or you switched to other conventional synthetic DMARD, they've tried a biologic. So prior treatments used can actually point towards those patients who might be difficult to treat because they're not responding well. Other things like your high titers for your rheumatoid factor and coexisting with interstitial lung disease has been associated with difficult to treat rheumatoid arthritis. So it's at diagnosis, it's important for the clinician or rheumatologist to be able to say, this patient is likely going to develop difficult to treat rheumatoid arthritis because of these risk factors. And accordingly, we tailor the treatment to target this patient and try and reduce the chances. So one of the things we advocate for is early treatment and reducing the time from diagnosis to initiation of therapy. This is a problem because we find most of the times when patients start developing symptoms of rheumatoid arthritis early on in the disease, they can go on for periods of months to even years before they've actually been put on their first DMARD. And the longer this period is between diagnosis to initiation of therapy, the less the chance of actually the patient getting into remission or low disease activity, or even a drug-free remission, which we find can happen with earlier treatment. So early initiation of therapy from diagnosis is key. Early initiation of biologic or targeted synthetic DMARD, especially for your patients that you've picked up that they've got poor prognostic factors or having poor responses to your conventional synthetic DMARD. So pick those patients early, escalate therapy early, and you can actually consider even doing adding the biologics earlier compared to the stepwise escalation or switching of your targeted synthetic DMARD. The other thing the doctors need to do is also to change to the appropriate targeted synthetic DMARD. So look at your patient, look at their profile, comorbidities, change to the appropriate biological targeted synthetic DMARD early in order to try and control the disease earlier, and then also correct the correctable things. So we mentioned obesity as a risk for the difficult to treat rheumatoid arthritis. So weight loss program, smoking cessation, which is smoking can cause poor response to therapy, poor adherence needs to be addressed with counseling with your patients, involving family, especially in your elderly patients, to monitor intake of drugs, and then also treat core infections like we mentioned, periodontitis, which can be treated so that you actually reduce the risk of developing the difficult disease. And then incorporation of your non-pharmacological measures, which are also there to augment your pharmacological treatment. And you need to bring this in early, especially in those patients you've identified. And you can now prevent the actual development, because once it's there, it becomes very difficult to actually bring these patients into a state of remission or low disease.
Moving on to our next question. What are the treatment and management strategies for difficult to treat rheumatoid arthritis?
Okay, so the treatment of difficult to treat rheumatoid arthritis, like most of our diseases, includes the pharmacological and non-pharmacological aspect of treatment. So ULA proposed points to consider when assessing your patients with difficult to treat rheumatoid arthritis. So before you've actually decided to do anything, you need to make sure you've managed or assess any comorbidities. As we mentioned, that may mimic the signs and symptoms of active disease, for example, your fibromyalgia, and also determine is there actually disease activity versus other things that could actually be going on with the patient. And you can use other things such as imaging with ultrasound, which can be used to confirm the presence of synovitis, subclinical synovitis, if present. So comorbidities need to be managed and assessed before you actually say this person has difficult to treat rheumatoid arthritis. Then treatment adherence should also be discussed. You mentioned you may be prescribing all these drugs to a patient and you find that they're either not taking them correctly or they're not taking them at all. So before you actually change or escalate therapy, you need to make sure treatment adherence has been discussed and has been assessed with your patient. And once all these considerations have been done, the next step will be your pharmacological management of this patient, which basically involves either an increase in the dose of the current medication, so whether it's a biologic which has two doses that can be considered, to up-titrate your dose, or to switch to another biologic or targeted synthetic DMARD, which has a different mode of action. So it's very, very important to realize that switching to the same mode of action, for example, one TNF inhibitor to another TNF inhibitor, may not necessarily cause a change in your symptoms or signs in a patient. So it's important to make sure that the mechanism of action is different. So for example, you're going to go from a TNF inhibitor to maybe using an interleukin 6 inhibitor, or using your abatacept, or maybe your B-cell depleting drug like your rituximab. So important to switch to a different mode of action for your biologic. And then when it comes to your non-pharmacological management of these patients, obviously we mentioned stopping smoking, dietary interventions, advising your patients on diets that have been known or shown to reduce inflammation, avoiding things that can increase inflammation, inflammatory diets that can make the disease worse, as well as a weight loss program to make sure your patient has a good BMI. Exercise should be incorporated whether with physio or self-guided exercise depending on the abilities of the patient. Introducing a patient to support group and group therapy is also important, as well as educating them on coping skills and stress management, because all these things have been shown to improve and actually help patients with this difficult to treat rheumatoid arthritis. There's also self-management programs that patients can be taught, as well as physiotherapy, use of orthosis and assistive devices, as well as psychological therapy, which is very important because most of these patients tend to end up with a lot of mood, depression, and anxiety. So there's need to use pharmacological therapy with psychologists, psychiatrists if needed, and even the introduction of psychotherapy in terms of medication when necessary and advised. So both pharmacological and non-pharmacological measures need to be adopted in trying to manage these things.
Now, moving on to our final question for the day. What are the future needs in the management of patients with difficult to treat rheumatoid arthritis?
Okay, so we mentioned initially that there were various definitions prior to the EULA definition in 2021. However, this definition still needs to be validated, as not all aspects of difficult to treat rheumatoid arthritis have been adequately captured in the three criteria that we mentioned before. And the result is because of the heterogeneity of the group, and hence it's difficult to actually capture every single patient with this single definition. There's also a need to develop a biomarker, if possible, to actually say specific biomarker is present. This is actually, by definition, a person with disease to treat rheumatoid arthritis, because this is more subjective versus the other objective criteria that may be present. And lastly, not one drug fits all. There's need for personalized or precision medicine, which takes into account a patient's unique characteristics, such as your disease severity, your likelihood to respond to specific targeted therapy. And this may help guide the choice of treatment based on information that is acquired from this personalized precision medicine. For example, if we just go through the guidelines that we normally follow, that start with the conventional synthetic DMARD, escalate therapy, then switch to a biologic or targeted synthetic. Not every biologic or targeted synthetic or conventional synthetic DMARD for that can be good for or the correct treatment for every patient. So the future is in precision medicine, where then we can use things like synovial tissue sampling or genomic information, which then can help in the future to develop maybe biomarkers that can capture each patient's unique biology, their disease phenotype, and their likely response to therapy. But however, this is still work in progress, and despite efforts, this hasn't been achieved. There have been studies that have been shown that when patients get synovial biopsies done and they're examined, they're actually able to predict response to specific biologic treatment. But as you can imagine, this is very invasive and the cost invasive, and not every country or place can be able to do this. So really the need is for there to be non-invasive biomarkers that can help predict response to specific therapy, so that you tailor your treatment on a patient-to-patient basis. Because biopsies have shown that at an individual level, there is differences in the degree of inflammation, the degree of lining, hyperplasia of the synovium, as well as the inflammatory cell components vary from one patient to another. So therefore, we definitely cannot have one drug fitting and treating patients and getting an equal or good response in everyone. So the difficult to treat patients will remain until such gaps have been filled out. And lastly, we need to be concerned and cognitive of our resource-limited nations who do not have access to biologics and targeted synthetic DMARD. More work needs to be done in future to get these drugs to become more accessible. Like we said, Eula mentioned that rheumatoid arthritis is a medical emergency. If not treated early, patients die earlier. Their mortality years by 10. You lose 10 years from your predicted mortality if you develop rheumatoid arthritis. So we need to get these drugs available to all nations. If possible, it's a wish and a dream. Yes.
Dr. Rutendo, a very big thank you for joining us on our podcast today. Your expertise on difficult to treat rheumatoid arthritis, I'm sure, has truly enriched and benefited our audience. Thank you so much for joining us.
Thank you so much. I hope we all benefit, and we identify all these things that need to be done in the future with management of our patients.
Thank you so much once again, Dr. Rutendo. We're looking forward to many more podcasts together.
Definitely.
And to our audience, a very big thank you for joining us. And remember that this podcast was brought to you by MedSynapse, where medical professionals connect, discuss, and collaborate globally. Be sure to become an active member on our MedSynapse platform to engage with doctors from around the world, exchange knowledge, and continue learning together. Until next time, goodbye and take care.